Hello and welcome everyone. Today we'll be discussing the convergent model of coagulation. The cell-based model of coagulation was introduced around 20 years ago. It offered a significant improvement over the older cascade or the waterfall model that we know of coagulation. The cell-based model addressed several limitations that are there with the cascade model, which has been the foundation of our modern coagulation theory for over 30 years. The cell-based model had a notable impact on the development of new therapeutics for both hemostasis, that is stopping the bleeding, or thrombotic, that is preventing clot disorders. Advances in medical knowledge and scientific progress prompt a re-evaluation of the coagulation model to better address current clinical challenges and improve the health outcomes. The new model of coagulation is proposed, which integrates the innate immune activation and inflammation into an unified response to bodily threats. This proposed model combines the principles of cell-based and cascade models, aiming to expand the understanding beyond the current focus on hemostasis and thrombosis, leading to an innovative diagnostic and treatment for the modern medical issues. So, what is this convergent model of coagulation? The overview is that the model explains coagulation as an inseparable process intertwined with the innate immunity and the inflammatory response during physiological reactions to any kind of an injury. Evolutionary development in the higher organisms lead to specialized hemostatic, immune, and inflammatory response, but these are rooted in a unified ancestral response, similarly which is seen in even the invertebrates. So there is a crosstalk. So what are these? There is a significant interaction across the specialized pathways that enhance injury response, such as monocyte tissue factor expression induced by interleukin 1 and type 1 interferon, alpha thrombin triggering inflammation through protease activated receptors. Cross regulatory modulation also occur, that is anti inflammatory effects of activated protein C. Injury associated molecular pattern. Molecules like DAMP, which include cell free histones, nucleic acids, HMGB1, play a role in the intersection of inflammation with coagulation. The DAMPs, initially identified as critical to inflammation and immune response, are now recognized as they have an important role in coagulation activation as well as its regulation. They modulate coagulation enzyme kinetics, activate coagulation enzymes, act as alternative cofactors, and increase anionic phospholipid availability. The procoagulant surfaces and the neutrophil extracellular traps, that is the nets. Dams extend the concept of the procoagulation surfaces by inducing nets, which accelerate the thrombin generation. Dams have been observed to have procoagulant effects at physiological concentration, not just in pathological circumstances. The role in clot resolution and healing. DAMP also play a role in resolving the clots, repairing damage, and facilitating healing. The examples are plasmin activation by CFH activated factor 7 or CFDNA activated factor 12 potentiated by HMGB1. Plasmin activity modulation by cfDNA or CFH indicates local damp composition and concentration importance in physiological roles. Inflammation mediated damp homeostasis. Proper regulation of the damps is critical for healing, with macrophage derived apoptosis inhibitors clearing the HMGB1 and calprotectin during stroke recovery in mouse models. Dams directly participate in the healing process. Example, the histones interaction facilitating plasmin-induced cell migration and HMGB1 promoting cell migration and proliferation in keratocytes, fibroblasts, and the endothelial cells. So how does this coagulation convergence with innate inflammation and immune activation? The procoagulant role of the DAMP, as we have already described, is because of this factor, that is the tissue factor and the factor 5A in the prothrombinase complex. Amplification of the thrombin is enhanced by DAMPs, activating the platelet von Willebrand factor axis, leading to the recruitment of intrinsic coagulation pathways through contact activation of factor 12 and factor 11 by polyphosphates, cfDNAs, and cfRNAs. Propagation of the coagulation is facilitated by the expression of the coagulant active phospholipids on the cell surface, often signaled by the pattern recognition receptors, which are key components of the innate immunity. Nets and clot formation. The nets play a crucial role in coagulation by facilitating coagulation complex assembly and promoting the crosstalk between the neutrophils and the platelets. Dams from the neutrophil activated platelets and activated platelet expressing dams recruit and activate neutrophils, creating a feedback loop. Net derived dams like calprotectin enhance platelet homogeneity and recruit neutrophils, contributing to the clot architecture, biomechanical strength, while also providing resistance to fibrinolysis. Now, what are the cross-regulatory mechanisms? Dams are integrated into the cross-regulatory process between coagulation, inflammation, and innate immunity, ensuring controlled localization and concentration to prevent damage to healthy tissues. Thrombin and activated protein C can degrade the dams like CFH and HMGB1, while thrombomodulin binds and neutralizes them. So the TM and protein C co-signaling inhibits the pro-inflammatory pathways activated by the HMGB1. Inflammatory responses such as acute phase response driven by interleukin 6 increase the production of CFH neutralizing proteins like C-reactive protein and fibrinogen. Innate immunity mechanisms neutralize the damage through oxidative processes and complement pathways such as C4 binding to the CFH inhibiting its procoagulant activity. Now, how is the complement system acting over here? The complement system contributes to the dam regulation. For instance, the complement C1q co-signaling with the HMGB1 to promote the anti-inflammatory monocyte differentiation. So, why is this model that we have discussed of innate immunity and coagulation relevant to us? It is relevant to us because it was highlighted during the COVID-19 that there is a critical role of coagulation in the management of these infections. The severe immunothrombotic manifestations in COVID-19 were not effectively managed by increasing the dose of heparin or the antiplatelets, underscoring the need to better understand how coagulation is so closely linked with sepsis. Historical insights into the coagulation and inflammation. Research since the 1990s and 2000s identified significant link between coagulation and inflammation, with the key anticoagulant protein, activated protein C, antithrombin, and TFPI being significantly reduced during sepsis. Early trials with these proteins in sepsis models showed promise, but large-scale trials eventually failed to reduce mortality and proposed hemorrhagic risks, raising questions about the true therapeutic potential of these particular proteins. Challenges with simplified models. The failure of anticoagulant therapies in sepsis may stem from oversimplifying the factors. Better understanding the coagulation, which has traditionally been viewed as a bidirectional manner. So, the complex multidirectional relationship between bleeding and thrombosis, especially in critical illness, may have been overlooked. That is why we had failures with the trials. Gaps in understanding the thrombotic disorders. The emergence of vaccine induced immune thrombocytopenia, that is VITT, and similar disorders have revealed significant gap in our understanding, particularly regarding how the innate immune system responds to perceived threat and is triggered and amplified. These gaps extend to other immune mediated conditions such as antiphospholipid syndrome, where antibody binding induces procoagulation and proinflammation, including increased NET and tissue factor induction. So there are also broader implications. The convergent model relevance lies in the potential to address these gaps by providing a more comprehensive framework to integrate the immunity, inflammation, and coagulation. This model also helps to improve the diagnostic and therapeutic strategies for conditioning where traditional approaches have clearly failed, particularly in cases involving chronic, low-level immune-mediated tissue damage. So where can this model actually lead us to? The dams which mediate the innate immunity and inflammation are increasingly recognized as significant contributors to thrombotic risks in various conditions, initially noted in critical illness and trauma-induced coagulopathy. The relevance of dams extends across the multiple medical specialties, influencing thrombotic risk in conditions like ischemic stroke, inflammatory bowel disease, SLE, rheumatoid arthritis, vasculitis, chronic kidney disease, and cardiovascular risk. The limitations are the conventional therapy have their limitations. That is, the treatment that we give targeting factor 10A, thrombin, platelet aggregation are often ineffective and undesired in conditions where inflammation-induced thrombosis occurs alongside a bleeding risk. Emerging therapeutic approaches, DAMP targeted therapies. Proposed therapies include chelating agents for these proteins, degrading agents. However, these are mostly in early stages and limited to animal models only. Extracorporeal strategies, techniques like hemofiltration, adsorption cartridges, and cutoff of membranes have been investigated to remove these DAMPs, cytokines, and other injury associated molecules in critical illness, but these have not yet been shown consistently to improve patient outcomes. What are the challenges and the opportunities? A significant challenge is in the inclusion of patients in studies based on severe clinical parameters rather than biological definitions. Example, DAMP levels, coagulopathy. This approach limits the effectiveness of potential therapies. The lack of lab based prognostic tools to accurately measure and assess DAMP levels and their relationship with coagulation highlights a need for more precise patient selection and treatment selection. So, what are the future directions? We need quantification and prognostication. The dose dependent procoagulant effect of DAMPs suggests that measuring circulating levels could help predicting outcomes. NET assays could expand the capabilities of coagulation lab and assist in disease stratification, particularly in conditions with specific coagulopathies. We need more multidisciplinary and combined approach. Moving beyond studying individual DAMPs in isolation, there is a potential for innovative multidisciplinary approach to combined anticoagulation, anti-inflammation, and anti-immune activation therapies. This could address the limitation of the current treatments from complex, multifaceted conditions. So this diagram here basically summarizes the convergent model. So we have three responses: the coagulation, the platelet neutrophil activation, and the inflammation. So in the coagulation, the DAMP-like cell-free histones and HMGB1 initiate the coagulation by inducing tissue factor, creating porocoagulant surface on the endothelial cells and the monocytes. The thrombin generated in this process can uh, not only forms clots but also activate the platelets and triggers the pro-inflammatory response through the pars. Okay, so next we have the platelet neutrophil crosstalk through these DAMPs. The DAMPs facilitate the interaction between the platelet and the neutrophil, facilitating the netosis, which enhances thrombogenicity. For example, the calprotectin S100A and HMGB1 are involved in activating the neutrophils and platelets, and the cell-free heme induces the netosis. So next is inflammation and immune activation. The DAMPs released during the netosis activate the endothelial cells and monocytes, leading to capillary leak and release of inflammatory cytokines. So you can see the cytokines are released. This amplifies the immune response and further promotes coagulation by exposing the subendothelial tissue factor and inducing monocyte tissue factor expression. So we also have feedback loops, that is thrombin. While thrombin activates platelets and drive coagulation formation, it also activates activated protein C, which then degrades the CFH, establishing a hemostatic loop that regulates the coagulation process. You also have netosis and TFPI. So netosis releases the neutrophil elastase, which inhibits the tissue factor pathway inhibitor TFPI, thereby enhancing thrombin generation and promoting further coagulation. So the implications are DAMPs orchestrate a complex and interconnected response involving coagulation, inflammation, and immune activation, all of which are crucial in maintaining vascular integrity following injury. Understanding this interaction is critical for developing therapeutic strategies, especially in conditions where traditional therapies have failed, and we need more better understanding of this strategy and targeting more broad pathways so that we can impact the patient outcomes. Thank you for your patience.